Good morning. I'm Mike Klassen, Vice President of Public Affairs for the BC Care Providers Association and Engage BC. I hope that you've been enjoying these fabulous sessions that have been taking place so far, and I know that today's programs focused on the theme of reinvention will be equally rich with ideas and insights. I'd like to welcome you to today's plenary panel called Redesigning the Future of Seniors Care. As we begin, I would like to acknowledge that we are hosting this meeting on the traditional lands of the Coast Salish peoples, including the Squamish, Musqueam, and Tsleil-Waututh nations, and extend our appreciation for the opportunity to hold this dialogue here today. This session has been made possible due to the support of our sponsor, Blue Leaf. Thank you, Blue Leaf. If you've not already done so, please visit Blue Leaf's booth and the booths of our other fantastic exhibitors. Today is the last day of our 2021 annual conference, and we will begin by hearing from an eminent panel of experts. The devastating effects of the pandemic on the elderly living in long-term care homes shocked and outraged the public and moved many to demand system reforms and increased accountability. In Canada, these calls have led to a process of creating new national standards, though what that means is yet to be determined. It has been given a budget of $3 billion over 5 years by the federal government, which translates to about $65 million annually for British Columbia. This funding is certainly a good start, but governments have been loath to make big spending commitments to support seniors. Real change will require exemplary leadership from the community and our political leaders, and the courage to see that reforms go through. While COVID-19 has thrust seniors' care into the spotlight, those of us working within the sector will tell you that these calls for change are hardly new. Many of us have been calling for sector reforms for years, if not decades. Our aging population has been likened to a rising tide. When the water is around your ankles, it's okay. Up to your knees, you can keep ahead of it. In just over a decade, however, the water will be above our shoulders, and then we'll be asking why we didn't act sooner to prepare for a society where 1 in 4 of us are retirement age. Which is why this dialogue and others like it are important, and I am so delighted to have our panel here to discuss how we resource and fund a new model of care, how we organize its delivery, and what examples we can use as part of this reform. And now I'd like to introduce you to the members of our esteemed panel. Dr. David Grabowski is a professor in the Department of Healthcare Policy at Harvard Medical School. His research examines the economics of aging with a particular interest in the areas of long-term care and post-acute care. Marc Kinna is the president and CEO of Baptist Housing and has been a long leader in our sector. Marc holds a business degree from UBC and an MBA from Trinity Western University with a specialization in nonprofit and charitable organization management. Professor Alex Mihailidis is the Associate Vice President for International Partnership at the University of Toronto, as well as the Scientific Director at the AgeWell Network of Centers of Excellence, which focuses on the development of new technologies and services for older adults. He is a professor in the Department of Occupational Science and Occupational Therapy at University of Toronto and in the Institute of Biomaterials and Biomedical Engineering with a cross-appointment to the Department of Computer Science of UT. And Dr. Sean Spina is the coordinator of clinical services at the Royal Jubilee Hospital, clinical associate professor with the UBC Faculty of Pharmaceutical Sciences, and an adjunct professor with the University of Victoria Health Information Services Sciences faculty. Sean is the principal investigator of alternatives to traditional hospital care offered in monitored environments, the so-called at-home. Panelists, I know this hour will go by quickly, so I'd like to invite each of you to provide your own brief opening remarks, and I think I'll start with you, Dr. David Grabowski.
Yes, thank you. And first of all, it's great to be here with everyone. So COVID absolutely devastated U.S. long-term care, both providers, recipients, and our caregivers. And given this is a session about redesigning the future of care for older adults, I'd love to think about sort of two broad reforms that I think would be relevant for the US and in Canada. So the first reform that I think would be quite productive would be to grow home and community-based care. Let's get as many older adults as possible out of nursing homes and other residential care facilities, get them back to where they want to be, and that's in the home and in the community. So that's the first major policy goal. The second major goal is we need to redesign nursing home services in the US and I think in Canada as well. We have too many big institutional buildings that have 2, 3, 4 older adults per room. We need to grow those small home models, 8 to 12 older adults living together. It's their home, they're directing care. The staff who are working in these communities are empowered, are valued, paid obviously a living wage. That's how we change long-term care. That's how we redesign the future. It's both growing home and community-based care, but recognizing there's always going to be a group that needs residential care. For those individuals, let's make certain it's a small home model that really values older adults. Final point, these two models are often seen as conflicting. I think that's a false dichotomy. We need to do both. Let's not pit residential care against home and community care, but rather grow both models. Thanks, Mike.
Thank you, David. Alex, I'll go to you, please.
Yeah, thank you very much, first of all, for inviting me to be part of this panel. It's a great opportunity. And I think David started off the discussion perfectly, and I'll build off of that. I completely agree with the two-prong approach that David described in his opening remarks, where we think that a significant role can be played by AgeWell and by other organizations here in Canada is by using technology to achieve those things. Looking at the role of technology to keep older people in their own homes, to provide tools to their family caregivers and clinicians that can allow them to provide the care that may be required, whether the older person is quote unquote healthy or whether they have mobility or cognitive impairments. And we are working on a variety of these technologies in Canada. In fact, Canada has emerged to be one of the world leaders in the age tech sector, as we're calling it. And this includes anything from smart home services to apps to artificial intelligence, and even several pilot projects we're running right now on the role of robots in the home that can provide care to these individuals to keep them in their communities as long as possible. Building off the second point about looking at the redesign of long-term care homes in Canada, this is something that is critically needs to happen right away. And one of the other hats I wear that I'm happy to discuss more in this panel is I am chairing the technical subcommittee for the Canadian Standards Association that is developing the new standards for long-term care homes, and specifically looking at the buildings, the infrastructure themselves that is required to support the level of care that is necessary in order to make these homes, truly that, a home where these individuals that require that level of care can feel safe, secure, and obviously where we will prevent future pandemics from occurring through proper infection prevention and control measures as well. Thank you.
Thanks very much, Alex. And I'll just mention that I attended one of AgeWell's labs in the fall of 2019 in Toronto and really enjoyed that creative process and bringing the people to and the work that AgeWell has been doing. I'll just remind all of our viewers to go to slido.com, enter the code BCCPA to come in if you want to answer at least some questions for our panel today. So I'll go now to Sean Spina. Doctor, can you maybe give us a few opening remarks, please?
Good. Thank you very, very much, Mike, for having me here. It's truly an honor to have been invited to participate in this panel. Today I woke up this morning and started to put on my suit and tie, and like I've done for the last 22 years. And then I thought to myself, this panel is looking at redesigning the future of healthcare and the seniors' care. And it dawned on me that we need to break from sort of these normal traditions that we've done over the years if we really want to redesign the system. So here I am in a golf shirt, and since it's Go By Bike Week, I tossed my keys in the drawer and rode my bike in today, and also wearing my orange shirt in acknowledgement of the 215 children found in the Kamloops residential schools this past week. I do think that we have opportunities to think about things differently. I believe building on what has already been said about needing to use technologies to support care and aging in the community is very important. And we know that delivering services to patients and supporting the care providers so that they can provide the services to their families and loved ones, whether it's a family care provider or a formal care provider, they need to have the supports to actually care for people where they want to be. Through the work that we've done, we have recognized that the people who we're caring for actually do want to be at home, building on the earlier comments where we need to support the system so that they can be there. One of the pieces of work that we've done in our research program is providing that data, because we believe that data drives decisions, and a lot of the patient experience measures as well as the quantitative data, I think, will be instrumental in really supporting the change that needs to happen as we redesign the way we deliver care.
Thanks very much, Sean. And Marc, can you give us a few opening remarks, please?
Sure, thank you. And it's a privilege to be a part of the panel. Thanks for inviting me. And as I think about this from an operator's perspective, so much of the last year has been about getting through. We all, as providers of senior care, want to see the end of the pandemic. And it's all about keeping our team safe and our residents safe and getting to the other side. And I applaud all of my peers across BC for the great efforts to do that. And I'm proud of what we've done in BC to keep seniors safe during this pandemic. What's interesting about our context at Baptist Housing is that we're trying to redesign a care home during the pandemic, and I'll share a little bit about our experience later on in the session. But we're looking at a rebuild of a very aging building that's not suitable for the care that's been provided. Some of the things about sort of poor care environments that we've heard in the other opening remarks are lived out every day at that location, and that's what we need to fix and change. What's unique is that because of the pandemic, we've seen that the partnership of government and through the Health Authority of Vancouver Coastal Health, we've seen a great partnership to come around what it could look like in a different redesign, a redesign that reflects the learnings of COVID and some of the priorities that come out of the COVID experience. And so that's really unique, because often with our relationships with government, as we all know, it's a bit of a hug and a shove. You want to work well together, but there's tensions there just because of the relationship, because of tight funding. And here we're seeing an opportunity to actually work together to do something that's a bit different, and I would say not necessarily innovative, but certainly is a departure from what we would normally see happen within the BC funding environment. So I'm pretty excited about that.
Thanks very, very much, Marc. All right, so we're going to go to some questions now, and then we already have a question coming in from our Slido. Just a reminder, slido.com, enter the code BCCPA if you'd like to have a question asked to our panel. Alex, I'm going to start with you. I want to talk a little bit to the national standards. You mentioned you're a part of the CSA, which is the sort of the built form of the sector. Maybe tell us a little bit about what your expectations are for that panel.
Yeah, so the expectations is that we're going to develop a standard that is reflective of the needs of long-term care homes here in Canada, that is reflective of the feedback that we are requesting and receiving from a multitude of stakeholders, right from residents of long-term care homes themselves to obviously operators of long-term care homes, caregivers, policymakers, builders, etc. In order for us to truly make a standard that's going to be as inclusive as possible. The other expectation is that we are going to develop a standard that's not just going to sit on the shelf at the end of the day, that we are working really closely with policymakers, the federal, provincial, and territorial governments, and again, the long-term care home sector themselves, in order to develop a standard that will hopefully be adopted. And it may not be mandated by the governments themselves, but if we can get buy-in from the ground up, then hopefully we'll see a trend where these homes want to adopt these standards of care and meet and surpass the bar that we're setting in them. So that's really the hope. The other aspect too is that yes, our standard is focused on things such as heating, ventilation, and air conditioning, air quality, design of furniture, etc. But there is also a sister standard, so to speak, being developed by HSO, the Healthcare Standards Organization, that is focusing on the level of care that should be provided. And so our goal is to work hand in hand so that each of these standards reflect each other and support each other as well. And that obviously our standard ensures that we're providing the facility that's required to provide the best standard of care as possible.
Just as a follow-up to that, Alex, do you know what the timelines are in place for this process?
Yeah, it's very quick, comparatively speaking to the development of standards. The goal is essentially within a year from now, there will be a standard published and out there. We will have draft standards ready in early 2022 for public comment. That will be taken into consideration as we move forward. But again, hopefully by a year from now, we'll have a standard that's completed, translated in both official languages, and ready for us then to start an education and knowledge dissemination plan moving forward.
Thanks very much. David, I want to talk to you about the experience in the United States. It feels to me that even though there were some really terrible stories that came from both sides of the border, the narrative is quite a bit different. I think it is partly due to the way the system operates, but how do you think the experience of the COVID pandemic has affected the sector, and what do you sort of see is going to happen next?
Sure. So as I mentioned earlier, the pandemic really kind of devastated all parts of our long-term care system, particularly our nursing homes. Just I won't give you all the numbers, but it's pretty staggering, just the number of cases, fatalities, even fatalities among the caregivers themselves. I did a piece for the Washington Post during the pandemic that suggested that nursing home caregiver worker was the most dangerous job in America, more so than commercial fishermen or logging workers, for example, which usually rank towards the top of that list. So I do think there's a lot of attention, Mike, in terms of the second part of your question of where this sector is really going. We still see census way down right now, so occupancy is down. It's not clear if and when it's going to come back. It's sort of gradually going up. I think as more family members return to the workforce, potentially we'll see nursing home admissions increase. But I think it's going to be a while until we return to pre-pandemic levels. And it really speaks to what Alex and others were advancing in our opening remarks, that this is really an opportunity to grow home and community-based services. And the U.S. has talked about a major initiative under the Biden administration with $400 billion going towards home and community-based services. That sounds like a big number, but unfortunately, given all the needs we have among older adults, that's not going to go as far as we might hope. But ideally, it's helping with wages for caregivers. It's helping fortify a lot of the programs we currently have in place, and some new innovative models. So my hope is that as we've seen kind of occupancy census go down in nursing homes, we're gonna see a growth in home and community-based options, and the burden won't fall just on families on an unpaid basis, but rather that we here in the U.S. that policy picks up the slack, because I think this is where individuals want care. This is a part of our system that we've underinvested in for a long time. Hopefully COVID is an opportunity to really truly rebalance our system. Thanks.
Thanks, David. I kind of wonder, first of all, I agree with you that the sector has taken a significant reputational hit, and that's going to require us to redouble our efforts to try and convince people that these are good home-like environments, and certainly some of the shift that's going to be happening towards home-based care. will be a big part of what we're going to see going forward. So maybe Sean, you can talk a little bit about the at-home project and what hospital at home means that has been established in Vancouver Island.
Yeah, thank you very much. Hospital at home is basically putting a new twist on an old adage that home is actually best. If you think back in time, patients have been traditionally cared for in their home. And research shows that at home and in their community is the best place for many patients to receive the care that they need. And hospital at home, we started our model prior to the pandemic, and definitely through the pandemic, it has been catapulted forward. So we basically spun up our whole program in 6 months from March of last year until the fall. We admitted our first patient. But it's really an innovative model of care that uses a suite of healthcare technologies to provide hospital-level care. The patients are actually admitted to our hospital and under the care of us. And we provide that to people in their own home. So their hospital bed is actually in their home. And then through a combination of in-person and virtual visits, patients receive their safe, effective care from healthcare providers who are experienced in providing hospital-based medicine and acute care. Like as I mentioned earlier, despite being at home, they're still admitted to the hospital and all under the policies and procedures and processes of hospital. We've had to tailor those to healthcare delivery in the community. They're also under the care of hospital physician, nurse, dietitian, clinical pharmacist, the type of healthcare providers that you would see in acute care. And other programs have implemented this successfully in other countries, but it's a relatively novel concept in Canada. Island Health, like as I mentioned, over the last year has implemented one program, two-site prototype in Victoria General Hospital, as well as the hospital I'm in right now at the Royal Jubilee Hospital here. We also collaborated with Northern Health, and they have a model in place as well. And in order to determine how it's helping seniors at home, our at-home research team is doing a fulsome evaluation and research. We've interviewed patients and caregivers as we did this early learnings piece. We've cared for just yesterday our first 200 patients in our 18-bed virtual hospital, if you will. And the feedback that we've received from people as we collaborated with them and understood them and interviewed them through our research program, it's been astounding. They absolutely love being cared for at home. Similar to what David was saying earlier on, they have a reason for waking up. They love having their family around. They feel much more comfortable getting up and going to their own bathroom, for example, and being in their own surroundings. And they tell stories of not having, when they're in the hospital, they're just laying around in bed and not ambulating. And we know that when people get up and have a reason to get up, they recover much quicker and have less deconditioning. Through our evaluation, we're going to look at the delirium, for example, and we're also looking at how we apply this model to a long-term care setting. We know that when long-term care patients have an incident, if you will, in the care home, we traditionally bring them to a busy emergency room, which is chaotic and loud. And if we can bring the hospital to them in their own home, we're hypothesizing that it would be much better for them, for their families, and for the care that they need in the comfort of their own home, to reduce the different exposures that they have and hopefully minimizing the delirium, et cetera, and the stresses that causes on families.
Thanks very much, Sean. I know that it'll be very interesting to see how that program rolls out and how it might affect other parts of the care continuum as well. Marc, I want to talk to you about some of the experience that recent experience at Baptist Housing, who is seen as widely as an innovator in British Columbia. We have a really great agency called BC Housing here in BC. I know that you've worked very closely with that agency, but in particularly around some of the work you've been doing in West Vancouver with the Inglewood Care Centre. Would you be able to tell us a little bit about some of the work that's going on there that might be transforming how you do business?
Yeah, glad to, and I appreciate what Sean just shared about hospital at home, and just echoing back what David said earlier. It's really a both and. We need to do the kinds of things that Sean's talking about, but also rejuvenate the long-term care environments that are aging, and this is the situation for us in West Vancouver. We acquired through this opportunity last year to acquire Inglewood Care Center, which is like 58 years old, 230 residents, and many of the things around shared rooms and no in-room bathing. This aging building that has a very high cost of maintenance and repair, with larger households that, of course, in a COVID pandemic situation, have high risk of transmission of virus, and so this is the environment that we're trying to rebuild. And so we've started this process of rejuvenation of the site into a full campus, where there will be aging in place. There'll be an opportunity for people to live in full independence, affordable housing, workforce housing, which is desperately needed in that part of our city. Memory care and assisted living, and there'll be a mix of private and funded units there when we're finished. Our last rebuild of long-term care was in Victoria back in 2014. We completed the Heights at Mount View, which itself won a recognition award with the American Institute of Architects in their aging review in 2015. It was a deliberately non-institutional design and kind of emphasized the connection to nature and the outdoors. And it had two 20-bed households that were back-to-back on each floor with shared back-of-house space. And it was an innovative process and an innovative design at the time. And we actually built full mock-ups of what a resident room and a resident bathroom would look like. And we built those within our current long-term care environment so our team could consult with us on how care would be delivered once we build it. So we bring all of those things forward into our redesign of Inglewood. Yet what's different about it, and I shared this in my introductory comments, COVID's changed the whole dialogue. And where in our funded spectrum here in BC, you would see health authorities pushing for 20 to 24 residents living in each household, and kind of a higher density approach because that's what the funding would support. We're now into a great conversation with Vancouver Coastal Health, where we're shrinking down those households to 12. And I think if you think about some of the news that we've seen coming out of the U.S., where the greenhouse model is in play, COVID spread way less frequently with way less of an impact in those homes with those smaller household sizes. And so that's the size that we're building, still with shared back of house spaces, but also with the ability in an outbreak scenario to completely isolate each household from each other, and then some innovative design to help with what could happen to keep people safe and also in an outbreak situation. Vancouver Coastal brought together their learnings from COVID because, of course, they've got the full, all of the owned and operated plus the affiliate providers experience. And so they're making changes to their IPC guidelines around design and operation of long-term care. And they were willing to bring that even in draft form as it continues to unfold and be built upon. They brought that to the table to consult with us so that we could really partner to create a better environment for the future. And as I read Andre Picard's book and some of the criticisms and encouragements that he offers our industry, I was proud to see that we were actually following some of that advice and proactively trying to include it in the redesign. A couple of things that help kind of paint the picture of what it could look like. Coming off of each elevator lobby, we're going to have visitation rooms that will be accessible without entering each household, so that in an outbreak situation, we can sustain visitation, which over the last year was one of the biggest impacts. We know the value and the importance of visitation to each of our residents and their families, and how it impacts their quality of life and their longevity. And so those are being built right in. So, when they can't enter the household, family members can enter into those visitation kind of vestibules with the plexiglass barrier to keep infection out, but sustain the visitation, which is really important. And of course, there's a whole range of the donning and doffing and screening and all of how we've incorporated that in. But it's a pretty exciting time to be redesigning care. And what that could look like, and it's really it's great to see that the government and specifically Vancouver Coastal is partnering us to do that in West Vancouver.
Thanks very much, Marc. And I'm glad you mentioned the workforce housing and looking at the campus holistically. For those who aren't aware, West Vancouver probably has some of the highest real estate and the highest land costs in North America. And so it makes it very challenging to try and provide new sites to that, so to be able to reform and rebuild a site like that with that kind of planning in mind is going to be very, very, very helpful. Just remind our viewers as well to go to slido.com. We've already got some questions coming that we'll get to in a moment, but the code is BCCPA, and you can leave your questions there, and there's already some good questions in the box right now. Alex, let's talk a little bit about technology. When I think about the smart home revolution that's happening right now, the delivery systems that we all depend upon, it seems like now through COVID, can you give us a couple examples of how technology may be evolving the way we deliver the seniors care?
Yeah, absolutely. There's been great strides made in the past 5 years around, for example, the role of artificial intelligence in being able not only to detect changes in people's health in their homes, but actually predict these changes before they occur. And these are technologies that are starting to be rolled out right now. So these are not things that are in the future; they are the here and now. And so you can imagine the powerfulness of such a tool that can, not diagnose someone with, say, a cognitive impairment or something else, but really just raise an alert to the older person themselves, their caregivers, their clinical team, just saying, we're detecting something is off with this person, and so we may want to follow up and see their family physician, etc. So again, the role of these technologies in the home is not to replace care that's actually physically provided by families or spouses or whoever it may be, but really just another tool among a larger set of tools that we're already using in the care of older people in their own homes and communities in order to collect this information. We're also starting to see technologies that are being rolled out, though, also in long-term care homes as well. So specifically, different types of technologies to help with the social isolation issue that we've seen during the pandemic. Using very simple technologies such as tablets or whatever it may be that are designed specifically for older people to be able to stay connected with their loved ones in their social circles. And finally, the big trend we're seeing obviously now is telemedicine. Very quickly, the provinces across Canada and the territories got telehealth working in a very short time in response to the pandemic, and this is not going to change. So what we're starting to see are new technologies coming out that, again, make it easier for older people to connect to telehealth services, but also for data that can be collected in the home using very simple sensors, things that many of us already have in our homes as part of home security systems or whatever it may be. So motion sensors, wearable devices that we're all starting to see people wear, such as, smart watches, etc., that can, provide critical information to the person on the other side of that telehealth call that can really give them a good snapshot or picture, or again, a prediction of what may be going wrong with that person.
Thanks very much, Alex. So I'm going to go to some of our questions that have come in here. And interestingly, a lot of them are about that home-based experience, and we will talk a little bit about innovating the long-term care sector. But maybe I'm going to paraphrase the question from Dale Sheriff a little bit about aging in place. We know that there is a quest for aging in place, and a lot of governments and our leaders like to talk about it. But can you give us an example, either in British Columbia, Ontario, perhaps in somewhere in the United States, of where we're seeing this actually being realized and the resources are being put forward by governments? And I might start with you, Sean, with your experience, but maybe a couple of the others might be able to talk about that aging in place goal.
So what we've seen here with ours is the government has put in place a hospital at home, but we're more along the lines of having people who have an acute illness and caring for them in the comfort of their own home. And like we looked at with respect to COVID, we wanted to make sure that people are maybe trying to increase in our capacity within the hospital system. I think a lot of the technologies like Alex was talking about that we would put in place for aging at home is actually, we're almost piloting them and trialing them in acute care, very, very critical setting with our sicker patients, such that they can be used in more of an aging in place circumstance. The other thing is as we put more of the technology in place, we do have to look at infection parameters and how dirty things are, and so we're actually putting infrastructure in place with UVC technology to clean all the wearables and that sort of stuff to ensure that we're not transmitting infection across from patient to patient. And like Alex was saying, there is a bunch of technology that we're putting in place. Communication is one of the key things. When we did a formal public engagement strategy last fall for our model on Vancouver Island, and it was open to all of British Columbia, we heard loud and clear that communication was absolutely essential if patients were going to be cared for at home, and providing caregiver supports. Caregivers really want to support their family members who are sick at home, but they need that supports in place. And I think that's really an important aspect that can't get missed as we redesign this, the way we care for people.
Thanks, Marie Sean. Anybody else want to address the idea of how we can resource this, the goal of aging in place? David, do you have an example from the States?
Yeah, absolutely. And Sean's answer was great. And just to build on that, we don't just want older adults aging in place, but aging in the right place. And I think here in the U.S., the right place encompasses kind of a strong medical model. So we have a model here in the U.S. called PACE, the Program of All-Inclusive Care for the Elderly, which is a medical home model. I'm not certain how prevalent it is in Canada, but it's a really strong kind of the clinical side, Mike, is met there. Coupling that with long-term care services, I think that's where aging in place has been the right place. And then we have a lot of examples, unfortunately, of unmet needs, both clinical and long-term care related. But I do think it's pairing the necessary clinical services with the long-term care services. Thanks.
Thanks very much. I'm going to go to one of our questions from Slido from Karen Biggs, our past president and one of the formative leaders in our sector. Karen points out that most residents and families want quality of life and the best day possible for residents. How do we shift that focus from the medical model to a person-centered approach in the future? And I know that BC Care Providers has been doing a lot of work on developing a quality of life framework, but it's really putting that into action. And I might even start with you, Marc, and tell us a little bit about how you think we can deliver that person-centered care.
Yeah, thanks. It's really it's important that we start with the resident and we start with planning everything around them. And I think we can talk about that, and I think a lot of us have that in our hearts when we approach care. But we have to be more deliberate, not only in how we structure our environments and our programs within our homes, but also I think in regulation. And so sometimes it's difficult, and I think dining times are a good example of this, where licensing might tell us when a person, the window of time when a person can eat breakfast within a long-term care environment. And that doesn't suit every resident. Some residents want to eat outside of those times. And so the regulatory framework for person-directed care isn't necessarily in the same place as those preferences and desires. And so we as providers need to constantly be pushing for what's best for residents. And when I say what's best, that's not from a paternalistic point of view of us telling them what we think is best for them, but actually saying what's best for them is what they choose. And so if their choice and if their preferences push outside of what our regulatory framework and environment would dictate, then we need to push back on that and enter into that dialogue so that we can constantly be going back to what residents are saying and what they value.
David, I want to ask you about the greenhouse approach, which you've written about quite a bit and have been involved. It's been proposed as a way for us to perhaps mitigate the effects of future pandemics, but I mean, more broadly speaking, I think it does try and create that person-centered experience. Can you talk a little bit about that work that's being done?
Sure, and Marc already mentioned this earlier. There was a great study suggesting that small home models have protected older adults and their caregivers, which is a great result. But we did a major evaluation of greenhouse 8 years ago, we never thought of infection control once during that evaluation. We were just evaluating, Mike, the quality of life and the quality of care. And it turns out these models maximize exactly what Marc was just talking about: resident dignity. Residents get up when they want to. They eat when they want to. It's their home, not a facility or an institution. And so they really set their own schedule. They control this, and it turns out this shouldn't be surprising to anyone. They're much happier. They have a much stronger quality of care model because the residents feel dignity and have control over their lives. And I've argued that once you visit a greenhouse, it's hard to look at other nursing homes, and not just greenhouse, but any small home model that really stresses resident dignity and values the caregivers as well. It's really hard to go back and see an institutional nursing home. The catch is obviously it costs a lot more, and we have far too few of those models in the U.S., largely because it's really expensive. And the point was already made earlier. Do we tear down existing facilities? Do we rebuild? Sometimes we built greenhouses on existing campuses right alongside the legacy nursing home. But I'm hearing a lot of enthusiasm about the model here in the U.S. It'll be interesting to see, however, how that enthusiasm translates into actual spending, because I think that's really what it's going to take. Because currently these models are largely a higher income private pay model. Here in the U.S., most of our long-term care, especially nursing home services, are funded by Medicaid. How are we going to make a greenhouse model or another small home model work under Medicaid financing? And that's really the key question. How do we find the dollars for capital-based improvements? How do we make this model work for everyone? And so, Mike, my hope is that leading out of the pandemic, we don't just kind of invest at the margins, but really make these kind of major investments that can really reimagine nursing home services in the U.S. And hopefully Canada takes similar steps as have been discussed during this session. Thanks.
At the top in my remarks, I did say that governments have been loath to make these big investments that we see coming. I don't need to read the numbers and the scale and size of growth that we're going to be seeing for the aging demographic in both the United States and in Canada. So the numbers are quite daunting. So I'm going to try and mix a couple of questions here. I've got one from the panel here talking about the potential for technology and infrastructure changes having the potential of reducing the hours per resident day requirements. I'm not sure if that is the goal, but it's an interesting question. But how do we manage this growth? How are we going to be able to afford it, I guess, is essentially what we should be asking. And I'd really like to go around the panel, and I might start with you, Sean, and then go to Alex.
So I think in managing the growth, we have to actually figure out a way to deliver our care more efficiently. And further to that, building on the last comment, was we need to actually ask people what is important to them as outcomes and what are goals for them. And we talk about that when we train our acute care staff, but we sometimes forget about that when we look at the broader general caring for people in home. And one of the things that we've looked at is using the technology to make us more efficient. Something was really important to us when we started this project last year is I'm a pharmacist by training, and the barcode scanning to make sure we don't have medication errors and all that sort of stuff when we administer medications to patients. We implemented a thing as patients don't want to wear the wristbands that we require them to wear when they're in an institution, if you will. And we're actually trying to incorporate a way that we actually use facial recognition to link back to our EHR to confirm patient identity rather than having to use the standard scanning of the wristband, if you will, to give them the dignity that they are in their home and that is their house. The other thing is I think it's really important to figure out a way to balance their experience and how they like that and what their outcomes are with data so that we can present it with cost, a real formal economical analysis of the delivery of care is really important, because it's not just about dollars, it's about balancing those dollars against the outcomes that we're achieving. And I think if we can figure out a way to stop building facilities and having people age in place, we will be better off as a society.
Alex, with the costs growing and the demand growing for these services, is technology one way that we might be able to get some cost savings?
Absolutely. Technology definitely can be one of the tools that can be used. And, again, this ranges from, very simple technologies to more complex ones that are being developed right now. As the cost of technology comes down, these things and these new solutions are becoming far more viable in terms of providing care to seniors within their own homes or within their own communities, and even if that community does include long-term care. The other aspect as well that we need to consider is it is a changing demographic with respect to older adults, that as the baby boomers continue to age and take on that cohort, they have a much greater expectation that technology is going to be part of their daily lives, as it already is for the most part. And furthermore, that'll be part of their healthcare. And so that's something we need to consider as we continue to develop these technologies and start to put. The other way that also technology can play a role to drive these costs down is to really put the decision of the role and the use of technology more in the hands of the consumers themselves. And this is something that we're seeing as we conduct polls and studies with current and future seniors and caregivers, that especially after COVID-19, for example, in a poll that we conducted with approximately 2,000 older Canadians, the majority of them, actually 2/3, said that they are now willing to pay out of pocket for technologies that allow them to stay at home and to allow them to stay safe and well and healthy. And so, shifting more towards this consumer marketplace approach for these technologies, as opposed to considering them more as medical or health devices, which, as we all know, often requires further regulation, which increases the cost, but reduces the availability of many of these technologies, is something that we also need to start to seriously start to consider. And hence why a network like AgeWell, where we are developing these technologies, are working with some really interesting partners that you'd never really expect to be in the aging space, such as Best Buy. So a large, consumer big box store here is looking to get into the aging marketplace in order to make these technologies available to this demographic.
I've always said that the baby boom generation are going to be the biggest driver of change. I think that large, massive demographic shift that's happened, it's affected society all the way through. And so when I sit across from a member of parliament or a minister of health, I always like to tell them that the reason why we need to get behind these changes is because your voter base, that baby boomers that are out there, are the ones who are going to be looking for these kinds of changes. Marc, you spoke a little bit about regulatory oversight earlier on, and I'm going to quote Karen Viggs, who I listened to comment yesterday on a panel, I think on Monday. She said that we are regulated to death. I think I'm paraphrasing there. But do we have to kind of rethink how we're regulating this sector? And COVID may have had a big impact on that. And maybe I'll turn to David after that, just to give us a bit of a contrast to what's happening in the United States.
Yeah, I feel like I might be stepping onto a soapbox about this, and so you check me on that. But I think it's we have to start by thinking about what it would be like to be a spouse or a son or a daughter of a person in care. And so the loved ones of our residents in BC nationally are calling for accountability, transparency, visibility, and we should be, as providers, proud of what we're doing, or we shouldn't be in our industry. And so if I'm proud of what I'm doing, I've got nothing to hide. I'll be willing to bring it into the light to show people. And so we should welcome appropriate oversight and accountability. And I think our national dialogue about this right now, is well informed by what's happening in Central Canada and why what has happened. Ontario has been criticized for removing routine inspections and going to a complaint-based approach to licensing inspections, and so there's a lot of calls for more accountability, even in BC, based on that national story. Now, I would say in BC, things are a little bit different, and I would say better, but it goes a little bit too, perhaps too far sometimes. So we've got annual inspections, we've got spot inspections, we've got quality reviews, and then you add on, in the pandemic, hand hygiene audits and other, enhanced cleaning audits and other new accountabilities that they've added. We are really, we know our licensing officers, okay? We have personal relationships with these folks. And also in BC, you've got a very active Ministry of Health and health authorities who have even taken over the management of homes because of concerns about the way they're being operated. So you put all that on top of even the accreditation requirements and there's a lot of oversight and accountability. Some of it, much of it is redundant in cases where, we're doing a quality review, but we also are doing accreditation. And the content of those reviews, two different bodies, but the same content. And so that can be overkill when you're trying to manage your time and your efforts. And so is there a better way? I think there is. We need to have a dialogue and kind of figure out what does that look like in BC. We're doing sometimes too good of a job. And it could be burdensome to providers, yet from a family point of view and from a resident's point of view, there's a need for that and a call for that, and we should embrace that. So it's a both and, I think.
David, I imagine that regulations differ from state by state and sometimes county by county, but is there anything that Canadians can learn from the U.S. experience, or maybe vice versa?
We have the same tension that Marc just described. I think most providers believe that they're being regulated to death, whereas family members and other stakeholders, believe this sort of oversight is essential and we need more of it. And so I think much like Canada, we could get a lot smarter about how we regulate providers in this space. I would say there's a few things about maybe regulating those poor providers more, regulating better providers less potentially, maybe eliminating some of the duplicative regulations. And I also think we need to focus more in the US on financial accountability and transparency. That's been another, to the prior question about potential efficiencies. There's a lot of opportunity here to sort of follow the money and make certain that providers are spending the dollars the way that the policymakers had intended, putting those dollars back into direct patient care. We've had an influx of private equity ownership and other models. And so, yes, we need to continue to kind of regulate the care that's happening on the ground, but we also need to keep an eye on what's happening in terms of spending. And both of those, I think moving forward, we could get greater accountability and transparency on the financial and ownership side, while also maybe making the regulatory process a bit more efficient. Thanks.
I'm going to go to our questions again. Debbie Smethurst has asked a question. I'm going to try and paraphrase a little bit, but we've actually read about stories where older adults are sometimes paired with students as a way of providing student housing, and where somebody might be overhoused, if you'd like, in a large home with some extra space. Are these kinds of programs viable here in BC, and should we be looking at them? And maybe I'll start with you, Sean, just because of your experience with that home.
I think we need to look at all options, and when you pair up an older individual with a younger adult, I think that's a good way forward. And like I said at the top of the hour, I think we need to think outside of the box and outside of traditional ways of caring for people if we're truly going to try to do things differently in the future. And that is one example of putting someone else in the home, a stranger, if you will. But we need to assess how that's going and use that data to drive the decisions that need to be made going forward.
We've got about just over 5 minutes left here, and so I want to use the time perhaps for us to, if there was a big idea that will help to redesign the future of seniors care. We've heard some really excellent ideas and approaches in our dialogue, but is there something that we've missed that we should be thinking about in terms of providing that person-centered care, providing the support people need at home, and making sure that we can have a sustainable sector going forward? Maybe I'll start with you, Marc, and then I'll go to Alex.
I think that we've got a lot of great ideas and solutions on the table. Whether it's nationally, locally, internationally, and I think the time is right for us to actually make some change. But in order to do that, we actually have to work together and partner to collaborate around those ideas. And so, that means us taking advantage of government openness, taking advantage of what Alex talked about in terms of the public being willing to pay out of their own pocket for technologies. Like the tide is turning around some of these things. And so I don't think it's a matter of trying to find something better than all the great ideas and all the solutions that we're talking about. These are all great things that we're doing. We just need to leverage what's happening right now because of the pandemic, perhaps, and because of the shift in toward the baby boomers, to actually do a bit of a redesign and try more of these things to see if we can have better outcomes for residents. But we have to keep the client at the center of the dialogue and the center of the change. It has to come back to being all about them.
I know that BC Care Providers has been very proud to bring collaborative discussions involving labor, government, local government organizations that provide family caregiving services, and to try and come up with good ideas. So to kind of meet what you're talking about, Marc, which is that we all work together and try and redesign that future of seniors care. Alex, any sort of thoughts? You have this obviously excellent platform going forward with the national standards. What do you hope that you might be? What big idea do you think you would like to try and get across in that exercise?
Yeah, I think I completely agree with Marc's point around the collaboration aspect. The only way national standards are going to work is if nationally we're all in agreement that we're going to give it a try, and that means the provinces and territories working together with the federal government in order to say, yes, we will give this a try. We'll all work together, as opposed to situations we see now where we have some provinces already pushing back on the development of the standard and already reaching out and saying, you know what, no, we're not going to adopt whatever is developed here. We're going to do something on our own. And if we continue to remain in these silos, we're not going to achieve anything. And back to a point that Marc made, that this is not futuristic thinking. These solutions exist, whether it's technological based or anything else. It's a matter of us pulling them together into a package that makes sense for everyone. Again, keeping the seniors in mind as the core end user of whatever we're developing. But it really is about having collective impact by ensuring that we all adopt a common agenda and that we're all pulling in the same direction moving forward.
So we're getting very close to our time here. I'm wondering, David, can you give me something in about 15 to 20 seconds?
Sure. I really like models in the U.S. around home care that pay caregivers directly. I'm thinking of like cash and counseling. I don't think that's an issue that's come up, but this is a way to both encourage family caregiving and also support those caregivers. We have labor force issues here in the U.S. I know those are present in Canada, so this is a way to kind of do both well. Thanks.
Terrific. Thanks very much, David. And Sean, just give me your sort of 15-second big idea.
In a nutshell, when we look at the future of redesigning care, I think that we shouldn't be redesigning care for seniors. I actually truly think that we need to be redesigning care with seniors and understanding what is important to them as we move to that next level.
Thanks very much. And I really would like to thank all of you for this fantastic dialogue that I hope we can continue together, because we need to have big ideas. We have a very urgent task ahead of us to try and make sure that we deliver great care. I'd like to thank our sponsor, Blue Leaf, for sponsoring today's session. And of course, I'd like to thank all of you for attending and for those who submitted your questions. We have a really great program for the rest of today, including the Safety Den finale. So I hope that you get to go to the Safe Care BC Safety Den. This is always a fun event, and we get to find out who actually won. And of course, we have our exhibitors, our other booths, and Stephanie Staples this afternoon. Thank you very much. I'm Mike Klassen for listening.